we're spending money for legal consultation. And so when we submit our report, you can benefit from that. I engage people from Harvard, legal experts from Harvard working on. Is there some way to get around ERISA without getting into technical details? We think, one, of course, you can ask for so-called legislative waiver that it require act of Congress to pass that. And then within ERISA, there are ways to get around it. But it's you have to design your program in a very delicate way, weaving through this legal quagmire, I call it. And we are in the process of doing that. So my answer to you is no, ERISA it's restricting, but there are there are ways you can get around it, but it makes the design of a single payer very complicated.
And simplicity is one of the advantages of single payer, as I heard your presentation.
Yes.
Correctly. A couple of questions. I first saw Representative Miller's hand up, and then Representative Flood.
Thank you, Madam Chair. In your deliberations in Vermont, is Vermont looking at the sort of siloed, carved out areas of long-term care, workers' compensation, and even the VA system? Are they thinking about streaming those all together in the Vermont system, or will those things still remain outside? Have you gotten there yet?
Because, let's say, VA operates its own hospital, we do not think that you can actually change that. But then the question is, how do you rely on the VA hospital to provide services to the veterans? So that requires, rather than streamline everything into one integrated system, we're trying to coordinate it. The word I use is coordinate these aspects. On long-term care, that's a very tricky issue when really in the midst of studying it. Partly is that, as I mentioned earlier, long-term care involves much more than just medical services. If you do it right, it has to build up an infrastructure going all the way down to home care at least, if not housing. And with the modern technology, I want to tell you, Japan actually wires the elderly people's homes, which they can monitor the elderly's health. They can submit the urine samples. There's a very inexpensive gadget can actually do the urine analysis, send that results directly to a health center. The health center and also blood pressure. They can monitor the person right at their homes, but America is not there yet. What?
Workers' compensation.
Oh, workmen's.
Oh, I'm sorry.
One last little part.
By all means. But get your microphone, yeah.
Yeah, the workers' comp issue, which is really a huge issue in this state.
Yes, the workmen's comp is a major issue that is actually very difficult to integrate. And because its laws are specified. And so we're thinking of doing so-called carve-out for workmen's comp. And fortunately, that would not really impact on a single payer in a serious way, because workmen's comp is relatively a small part of the total expenditure on health care for United States as well as for Vermont. I do not know the situation in Maine.
Representative Flood.
Thank you, Madam Chair, and thank you for your presentation, sir. Very interesting. I have two questions, if I could, Madam Chair, and they're associated. I don't understand the government or the functionings of Taiwan. It was interesting to hear that. Prior to 1995, when you had the changeover in Taiwan, were there private insurance companies providing health insurance in Taiwan, or was that handled in some other way? Were there private insurance companies doing that business in Taiwan?
In 1995, there are private insurance companies doing business in Taiwan, and actually there was a flourishing insurance market. But the private insurance did not actually focus on health insurance, because health insurance is one of the most complicated forms of insurance. It's a service. It's not like pension. When you reach age 65, I pay you so much based on your contributions. Or life insurance, you're either alive or dead. And as soon as health insurance is most complicated, it's a service. Who is qualified to render that service? Is that service appropriate? And how much could a physician and hospital charge for that? Usually, a country does not move into private insurance until the insurance industry gets very sophisticated and also has a long time to develop. Taiwan did not reach that stage. So Taiwan had a private insurance industry, but very few of them offered health insurance. The kind of health insurance they offer is this. If you're in a hospital, I don't care how much it costs. I pay you, let's say, $1,000 a day. As long as you show me, the hospital certify you are hospitalized for 8 days, I pay you $8,000, regardless the disease and cost. Consequently, the market they penetrate is very small. And so that's why you had very little administrative costs. They simplify everything down to just pay the patient. If you're hospitalized, I pay you each day for so much.
May I continue with that?
By all
I might
means.
have 3 questions now, but that,
Oh.
So would you say, Doctor, then, that the private insurance industry situation in Taiwan was significantly different than the private health insurance industry that currently exists in Maine? Is that fair? Thanks.
Yes, it is.
And my final question. Then, was there a major impact on the use of insurance companies in Taiwan and a simultaneous impact on employment by people in those businesses in Taiwan? Did people lose jobs because we went to a obviously very efficient program? Were there outcomes, negative outcomes somewhere in the process where people were losing jobs and is that clear?
Yes. We investigate that because Taiwan tried to commission other people to evaluate what's the impact. And as far as I know, they could not find a measurable impact on employment. But the reason being, as I said, is they were very limited health insurance and very simple kind of health insurance. Then the insurance industry is growing, so if there were people lost their jobs, they would shift them to, let's say, life insurance. But in Maine, I think it will be different. And even in Vermont, that's the issue we're considering. Is if Vermont shift to a single payer, how many people may lose their jobs? How many new jobs could be created? And these are the important economic issues.
Thank you. Are there other questions? Yes, Representative Connor.
Thank you, Madam Chair, and thank you for coming in today. I think certainly a good deal of your presentation talked about the cost of care and kind of the weights between we want to pay less and yet we want to earn more. And that's, I guess, in a capitalistic society, that's human nature. One of the things that I think you also talked about is folks want choice. And I see here from your presentation that you did last night at Bates, there's a final bullet point on the second to last page where it says, some co-payment may be necessary to moderate demand for unnecessary services and drugs. And from where I sit, and I'm a former nurse, I think there are presentations say up to 50% of the care we provide is unnecessary. And so how, is that already in play in Taiwan, and how has that played out? Because I think it's great to allow folks to say, I want Cadillac care. I don't care if it costs $1 billion because I have that kind of money. So you're presently allowing that in Taiwan, or how does that work?
Yes, that's already in place in Taiwan. In our original design, what we did is we look at the studies and empirical evidence. You have to balance, let's say you want patients pay something, but you do not really inhibit their access to necessary medical services. How do you balance the two? Fortunately, what we discovered is there's a body of knowledge, it's called behavior economics. When people have to open their pocket book and take out their wallet to pay something, they become much more conscious about it. But if they have to pay, let's say it's $5, and you increase that to $8 or $10, that actually doesn't have such a big impact between $5 and $8. But it's this act, I have to take out my wallet and pull out of, let's say, $5 bill. So what we did is we designed it for Taiwan. People have to pay $1.50 co-payment for every visit. But we use that technique to say, if you jump the line, if you did not get a referral from the primary care doctor, you went directly to specialists, then you have to pay much more. It's dramatically more. It's $10. So they're conscious of, I pay $1.50 or I bypass the primary care doctor and I just go to the specialist directly. But another key point is people's sensitivity to price is much higher for drugs. So we impose a co-payment on drugs because studies around the world found if you give patients free drugs, roughly a third of them actually are thrown away. So that's one of the greatest ways if you want to offer free health care. So we impose a co-payment on the drugs. But we then, as well as a co-payment for hospitalization, with the rationale, once you're hospitalized, you don't have to pay for food as compared to if you stay at home. But then we put a cap on the total amount you have to pay. So you will not bankrupt or really become a financial hardship on the patients who have, let's say, chronic illness and major catastrophe. We do not charge, in Taiwan, they do not charge co-payment for children, for the elderly, and for certain chronic diseases. They're exempt. There's no co-payment for these groups. And for the poor people. The poor, the children, and elderly, and also for certain chronic disease, there's no co-payment.